And now we turn to the program for the day. Kat Reeves, or Kathleen Reeves, has named her program "I Sing the Body Electric," a process relational critique of compartmentalized medicine. Kat is well known among many of us in the Cobb Institute, and I think some of her friends from other places are here with us today as well. She is the community relations specialist for the Institute, and she brings her gifts, her many gifts, of small group leadership, creative imagination, writing, and editing to that position, as well as her genuine care for others. One of her most recent accomplishments in the Cobb Institute is the creation of our creative quarterly magazine. The name is Seasons, and she edits it to the delight of us all. It's a wonderful magazine. It's available online, free, and I recommend it to you. Kathleen works also as the spiritual care team coordinator for Pilgrim Place Senior Community. Today, in Cobb and Friends, she will lead us in a discussion of the fragmentation of modern medicine and the urgency of developing relational health care that attends to holistic well-being. She will share her analysis, complemented with stories of lived experience. In her words, Kat recognizes, and I quote, the undeniable emphasis in medicine on treating organs and isolated body parts, even at the expense of understanding the broader context of a patient's life. She'll make a case today for healthcare that attends to physical conditions, human relationships, psychological dynamics, and spiritual life. That is, medicine that attends to body, mind, and spirit. In the past, Kat has worked in acute hospital settings, so she has a vast experience in her background, including Riverside Community Hospital, Arrowhead Regional Hospital, and Loma Linda University Medical Center. In these hospitals, she worked in health information management, analyzing patient medical records in order to document surgical details and to discover and chart all of patient diagnoses. More recently, Kat has worked as a hospice chaplain and a facility chaplain with seniors. As a writer, Kathleen is a splendid poet, and she also contributed a recent essay on chaplaincy to the book, Preaching the Uncontrolling Love of God, Sermons, Essays, and Worship Elements from the Perspective of Open, Relational, and Process Theology. We had a program here recently with the editors of that book, and it is being read widely. So today we welcome you, Kat. We can't wait to hear what you have to say and then to discuss it with you. So thank you for being here, and take it away.
All right. Thank you, Mary Elizabeth, and thank you everyone for being here. Okay, so I sing the body electric. And the philosophy of medicine is a branch of philosophy that explores issues in theory, research, and practice within the field of health sciences. And it includes consideration of epistemology, metaphysics, and medical ethics, which overlaps with bioethics. And philosophy and medicine, both beginning with the ancient Greeks, have had a long history of overlapping ideas. And I intend to bring process thinking into the conversation. What is missing in Western modern medicine is this: we are stories within stories in communities of communities. And I want to make a disclaimer. The information provided in this presentation is for philosophical purposes and should not be taken as medical advice. Neither I nor the Cobb Institute has the ability to give medical advice. And I also want to add that although I'm going to be critical of the modern medical system at times, I know that there are doctors who are trying to have more control over their practice. but they often come up against the for-profit model that's currently dominating and is almost impossible to break free from. And medical schools teach to the compartmentalized model. Medicine used to be an art or a craft, but today it's a commodity. And the doctor is either the middleman or far removed surgeon who never meets his or her patients. It's a system based on misplaced concreteness that is targeting symptoms and isolated organs as and the health with little collaboration in physician culture. I'm going to weave stories and poetry throughout this presentation to give it a wholeness, the wholeness that I propose is missing in the modern biomedical model used in the United States. And I'll give examples of compartmentalization in medical treatments, and I will describe the body and its interrelational systems in constant flow and movement and beyond the body to look at the person as a whole bio, psychosocial, spiritual being. And I'll give examples of possibilities for integrated medicine and better communication. Tiny bits of matter are assembled to produce the standard model of the human body, which are broken down from cells to molecules, atoms, and beyond. This model of the body as thing has produced wave after wave of modern drug therapies and a minute understanding of anatomy. During my presentation, you'll hear about mechanical devices. These are not the body. And if I talk about a mechanical device and you happen to have one of those devices, just know that it's all about context. So the choices that we make for these devices really have to do with where we are at in our place in life and with the whole picture in mind. So please understand it in that context. So the poem, I Sing the Body Electric, celebrates the sensuality, the incredible capability of the human body, and the interconnectedness of all people. The body electric is a celebration of the body as dynamic and relational. A strange fact that nobody seems to act upon is this: the body you see in the mirror isn't your real body. The image you see of a solid physical object, stable and fixed like a table or chair. But in reality, your body is fluid, constantly changing, filled with numerous spaces and the host of trillions of bacteria. There is experience in all that has gone before you, compressing and moving forward. All of this is more than the you see in the mirror. So relational beings, bodies of relational beings in a biomedical system. I'm going to share a story. "85-year-old retired Wesleyan University professor Jeffrey Butler was suffering from dementia. Sewn into a hump of skin and muscle below his right clavicle was the pacemaker that helped his heart outlive his brain. The size of a pocket watch, it had kept his heart beating rhythmically for nearly 5 years. Its battery was expected to last 5 more. Each morning, his wife would help him from his narrow bed with its mattress encased in waterproof plastic. She would take him to the toilet, change his diaper, and lead him tottering to the couch where he would sit mutely for hours as he stared out the window. In his current state, his daughter would look at him and think of Anton Chekhov's quote, "Whenever there is someone in a family who has long been ill and hopelessly ill," he wrote, "there comes some painful moments when all timidly, secretly, at the bottom of their hearts, long for his death." A century after that was written, the wife and daughter had come to long for the machine in this man's chest to fail. He received the pacemaker in 2001 when needing surgery for a hernia. Without the device, the doctor, who had met him only twice, said that he could have died from cardiac arrest during the surgery, or perhaps within a few months. That time, the then confident pre-stroke Mr. Butler expressed extreme reluctance on the advice of his family doctor, who considered it over-treatment. Dr. Fales, who knew the Butler family well, continued to oppose a pacemaker. He understood the implications and the relationality and the need for quality of life for the Butlers. He wasn't alarmed by the concept of dying. But when the cardiologist suggested the pacemaker for the second time, Mr. Butler was too stroke damaged to discuss and perhaps even to weigh the trade-offs. The decision fell to his wife, anxious to relieve her husband's pain, exhausted with caregiving, and differential to doctors, and no expert on the high-tech medicine. She said yes. One of the most important medical decisions of Mr. Butler's life was over in minutes. His primary doctor was notified by fax. Mr. Butler or Mrs. Butler was given more government-mandated consumer information when she bought a Camry a year later. The system rewarded nobody for saying no or even wait. The pacemaker bought Mr. and Mrs. Butler 2 years of limbo, 2 of purgatory, and 2 of hell. In 2005, the age-related degeneration that had slowed Mr. Butler's heart attacked his eyes, lungs, bladder, and bowels. Clots as narrow as a single human hair lodged in tiny blood vessels in his brain, killing clusters of neurons by depriving them of oxygen. Partly deaf now, he began losing his sight. A few months later, he got lost on short walks, grew incontinent. He was collapsing physically, like an ancient shored-up house. In the summer of 2006, he fell in the driveway and suffered a brain hemorrhage. Not long afterward, he spent a full weekend compulsively brushing and rebrushing his teeth. His pacemaker kept on ticking. In 2006, desperate, Mrs. Butler and her daughter Googled looking for solutions. They discovered that pacemakers could be deactivated. In 2007, Mr. Butler got pneumonia. At first, the family did not seek antibiotics, but eventually he was hospitalized. Mrs. Butler beseeched his doctors and nurses to increase his morphine dose and turn off his pacemaker. It was a weekend, and the cardiologist on call refused authorization, saying that Mr. Butler might die immediately. And so came 5 days of hard labor. The family stayed with him while his breathing became increasingly ragged and his feet slowly started to turn blue. The family began drafting an appeal to the hospital ethics committee. But on a Tuesday afternoon, with Mrs. Butler at his side, Mr. Butler stopped breathing. He was pronounced dead. Inside his chest, his pacemaker was still quietly pulsating. A year after Mr. Butler died, the Heart Rhythm Society and the American Heart Association issued guidelines declaring that patients or their legal surrogates have the moral and legal right to request the withdrawal of any medical treatment, including an implanted cardiac device. It said that deactivating a pacemaker was neither euthanasia nor assisted suicide, and that a doctor could not be compelled to do so in violation of his moral values. And in such cases, it continued, doctors cannot abandon the patient, but should involve a colleague who is willing to carry out the procedure. And that's a story from Katie Butler's book, Knocking on Heaven's Door. Now, this presentation is not about death. However, I'm often going to use examples from the end of life or with serious illnesses, because that's usually when the fragmentation of the medical system becomes more evident. So, and you may be enjoying excellent medical care currently, but if you face an acute health emergency or as you age closer to your final days, fast medicine kicks in and leaves little time to weigh the options. Medicine as if an automatic pilot goes on in the direction of quantity over quality of life, and as defined by the doctor may not be your definition of life. And we saw firsthand that our world is indeed relational. When the COVID-19 pandemic hit the world, its effects reverberated beyond the infected bodies. Not only did the pandemic lead to a dramatic loss of human life worldwide, it led to an unprecedented challenge to public health, food systems, and the world of work. The economic and social disruption caused by the pandemic was devastating. School-age children could not go to classes. People could not attend church, social events such as weddings, funerals, parties. Loneliness became the second pandemic. We are social beings, and isolation was devastating. And this is not to downplay the loss of life. Rather, it is to show how these things are intertwined. Segmenting the body into parts is convenient, and it works in the anatomy books, but not in real life. Dr. Patrick Petrioni stated that a key principle in holistic medicine is that the human organism is a multi-dimensional being possessing body, mind, and spirit, all inexorably connected, each part affecting the whole as the whole being greater than the sum of its parts. He believes that doctors need to shift from a wish to cure patients to a sharing in the patient's journey. The systems of the body all work together all times to allow the body to continually adapt to varying stresses placed upon it. Your body is a prime example of a complex system. Many different interconnected parts interacting with one another lead to the emergence of the body as a whole. The body is a person situated in a story, and the person is a biopsychosocial spiritual being. And complex systems cannot be understood simply by understanding the parts. It is the interactions among the parts and the consequences of these interactions that are equally significant. Holism is an ideal, but we must consider that specialization has led to better outcomes. Holism as a gestalt must encompass reductionism if it is to study the relationship between the parts and the whole. In this case, we can look for balance, realistic approaches to modern medicine, isolate the parts to examine and diagnose, but then put them back together into the larger context when considering treatment. The biomedical model of medicine. I discovered Dr. Victoria Sweet, and she wrote that in medical school, she learned that the body is a machine or a collection of machines. The brain is a computer, the heart is a pump, the lung is a billows, the kidney is a filtering device. A disease, therefore, is a breakdown, and the doctor is a mechanic whose job is to find what's broken and fix it or replace it. The way of healing that comes out of this model is focused. It is taking apart, peering in, reductionist. But she has observed that this approach to medicine has allowed for wonderful advances and explains a lot, but not everything. The patients sometimes get better on their own, the importance of relationships, and the feeling effects of time. In this head, the all-baffling brain. In it and below it, the makings of heroes. So, American medicine. The armies of those I love engirth me, and I engirth them. They will not let me off till I go with them, respond to them, and discorrupt them, and charge them full with the charge of the soul. In 1977, Dr. George Engel wrote a piece called The Need for a New Medical Model, a Challenge for Biomedicine. According to Dr. Arthur Lazarus, things have only gotten worse. He writes in his article called The Decline of Whole Person Treatment in Modern Medicine that physicians practicing in the 1970s were free thinkers and private investigators guided by a deep understanding of their patients' social habits. Histories often referred to patients by their occupation. Mrs. Jones is a 53-year-old school teacher, rather than by age, gender, diagnosis, and body part. I'm going to tell you my father's story. My father died twice. We were unprepared for either of his deaths. 25 years ago, on a warm evening early in June, my and he and acid. Later, he started breaking out in a sweat and felt worse. My mother drove him to Kaiser Urgent Care. There he was triaged, seated in a wheelchair, and waited to be called. He waited until he collapsed in the wheelchair, and my mother screamed for help, and help came. He was rushed to the back in a clumsy attempt to attend to him, but his feet were dragging and pulling him as he was almost falling out of the wheelchair. And just like in the movies, there was shouting, rib-breaking pumps to the chest, CPR, a traumatic, almost violent, but life-saving act. Paramedics arrived. This was urgent care, not a hospital. More shouting and rushing, equipment coming out of boxes. Field intubation for assisted breathing, more shouts, arrest, ready, clear, got it, lost it, flatline, no heartbeat. Again, got it, no, nothing. Next up, defibrillator, over and over. My mother stood in the hall, frozen, watching the scene play out in slow motion. Then realizing that my father's life was slipping away, she became hysterical, shouting, "You killed him. You let him die. You made him wait." The staff ignored her. It was just another noise in the chaotic scene. My father was flatlined, cardiac arrest. Then a call for a syringe, the last resort, epinephrine. Epinephrine, also known as adrenaline, is a hormone that stimulates the heart and promotes the flow of blood. It is injected directly into the heart. 1 milligram of epinephrine every 3 to 5 minutes during resuscitation. I believe my father received 1 injection. Without an advance directive or a pulse, this CPR will go on and on until that last resort fails. Take into account that precious minutes are passing. My father's heart tissue is dying, tissue that will not regenerate nor heal. They got a sustained heartbeat from a severely damaged heart. My father was transported and admitted to ICU, unconscious, intubated, and on mechanical ventilation. He remained that way for 2 weeks. That was the maximum time before a tracheostomy would be required. They attempted extubation and he was stable. We thought we had a close call, but somehow made it through. He survived and modern medicine saved his life. There was so much we didn't know, but would soon learn, much too late. My father couldn't talk for the first few days after his extubation. His throat was irritated from the breathing tube. He put 2 fingers to his mouth as he did when he smoked. He was asking for a cigarette. We were in disbelief. I guess Dad is back and he's all right, I said. The cardiologist wanted to perform a heart cath to determine what caused his heart attack. A cardiac catheterization involves inserting a long, thin, flexible tube called a catheter into a blood vessel in the groin. The catheter is then threaded through the femoral artery and advanced into the heart. Contrast is injected and x-rays are taken. This is a routine procedure that is performed often. Many years later in my work, I would go on to read many of these procedures and often go to the cath lab to discuss these interventional radiology procedures with the cardiologists. But at the time of my father's heart cath, I knew nothing. After the procedure, the cardiologist spoke to my mother and me, and I still knew nothing. You see, she was in a hurry, and she spoke in another language, doctor speak. She had bad news for us. But if you give bad news wrapped in medical language, you aren't really saying anything. It's just a report, just the facts. But so much can be understood by those facts when you know how to interpret them. Years later, I could read a heart cath report and know who would die soon and who would live a normal life for many years. I could tell who would qualify for a bypass and who wouldn't. What the doctor told us is that my father wouldn't have a coronary bypass surgery. His heart had a lot of damage. We thought we had a close call, but somehow he made it through. He survived and modern medicine saved his life. My dad's diagnosis was CHF, congestive heart failure. He was given multiple prescriptions, including blood thinners, diuretics. The blood thinner Coumadin required regular blood tests and INR, international normalized ratio, to monitor clotting time. One of those questions I reflect on in hindsight was, why would they want us to drag my father back and forth and poke him with needles when they knew, even if we did not, that his heart would not last much longer? Going through the motions and not thinking much beyond protocols to the human element, to my father's quality of life for the little that he had left. He should have been on hospice, but that was 25 years ago. We should have Googled about it, but again, that was 25 years ago. Google had just been founded, so there was nothing to find quite yet. What followed for my father was a fast decline. His damaged heart struggled to sustain his body. It couldn't pump the oxygen needed, and that started affecting his brain. He had terrible hallucinations. He saw little monsters crawling around the furniture. He thought a plane crashed in the backyard and wanted to go out and save the pilot. His doctor suggested that we take him to a psychiatrist. A relational perspective on the body would have had them deal with the oxygen rather than medicate his systems. We added the unnecessary psychiatric drugs to his long list of meds, another doctor visit requiring my very ill father to attend. My father's heart declined. He was hospitalized again to get a stronger dose of Lasix. Our neighbor across the street was an RN and came over to ask how he was doing. She saw our lack of understanding in the situation. She saw our confusion. She sat us down and explained the situation of my father's CHF. Of course, she couldn't cross the line and tell us that he was dying, but looking back, she knew. She was in a bind, and it wasn't her responsibility to tell us. But she was the first person to take the time to explain in a way that we could understand. The next day, my mother got a call from the hospital advising us that we might like to get a priest. We were shocked. We were rushed to the hospital and ushered into a room where the doctor explained that my father was dying. He told us about my father's damaged heart. He told us more at that point than anyone else had, but we were blindsided. My father died in a hospital room that night with his wife and children around him. It had been a month since his heart attack. Years later, I would come to understand everything in my work in health information management and clinical documentation. It is sad, of course, that my father died. What adds to the sadness is the lack of communication or even consideration for my father as a human being, a man with a family, a man who might have liked to spend his final days saying goodbye to his family and friends and to speak to clergy and maybe ponder the mystery of death. The doctors had a name for my father. This is a 59-year-old male with arteriosclerosis with CHF due to an SD elevated myocardial infarction. His name was Alexander Ramo. The medical conveyor belt. While a considerable number of medical practitioners enter the field of with altruistic intentions aimed at providing aid and facilitating recovery, the prevailing medical framework tends to constrain innovative thinking and divergent approaches. Excessive healthcare victimizes many people in this country. Our oldest and most vulnerable patients are subjected to tests, procedures, and medications that have little or no value to their health. What is worse, many are having medical interventions that prove harmful to them. So if you're willing to be an advocate for your parent or for yourself, you can prevent these excesses. Patients and family members need to take control of their healthcare process and to know that as people become older and more frail, often less is more. Margaret Fitzpatrick, author and speaker and advocate for a more rational approach to healthcare as we age, wrote, "In my past training, a common assignment was to create a care plan for a patient. The age and medical condition were given to us, and we were to outline a plan for that patient's care. We were never encouraged to speak with the patient to determine what his or her individual goals were or to ask what was the most important to him or her. The assumption was that each complaint and symptom could have a test, and every test a diagnosis, and each diagnosis a treatment." Hospitals are a normalized part of modern life, and this is especially true when it comes to dying. It's estimated that around 60% of Americans die in hospitals. Dying in hospitals away from extended family and friends in an unfamiliar bed understandably necessitated changes in the understanding of endings and how people defined the good death in the 20th century. Fewer personally witnessed death, making the final days of dying disturbing in ways that they had not been before when it was familiar to everyone. Gods of the emergency room. This is a story about a patient that I had in hospice. She had end-stage COPD, chronic obstructive pulmonary disease. She was dying, and she was a high risk to go to the ER. Hospices get penalized when patients go to the ER. So because Medicare considers it our job to educate. And if they call 911, we didn't do our job. And you can feel free to ask me questions about that later. But what we do in this situation is send in the chaplain and the social worker. So I sat with her and I listened to her fear of death. She had gone to the ER many times, and she seemed to believe that if she went to the ER, they could always save her. I gently explained to her that when her disease reaches that point, that she goes into respiratory failure, death will come, even if she is in the ER. I talked about hospice and what we could do for her by making sure that she was comfortable at home with her daughter and her cat, that she would have no anxiety or discomfort. I talked about the contrast with ER, the bright lights, the noise, the painful CPR, intubation, which involves a tube being inserted through a patient's mouth and down into their trachea. And she told me, I have no fear of the ER. I don't mind being intubated. I've been intubated 17 times. With that, I stopped. I respected her wishes. She was 100% certain that she would survive if she went to the ER. I'm not interested in trying to change someone's mind when they're dying. We need a culture change before that point. And my patient did die in the ER that same week. We need to know that doctors can't make us live forever and that death is not failure. Trying not to die is our primary experience at the end of life. And in this way, we end without any ending, and we're gone without any leaving. Primary care physician practice prestige takes a nosedive in the 1970s and the 1980s. The introduction of a new technology such as the MRI and the CT scan, as well as improved image quality of ultrasounds, created the need for the specialist. And this is really kind of the beginning of compartmentalized medicine. Doctors are no longer artists, they're assembly line workers. Scientific advances diminished the primary care physician status, and a renaissance was underway for the specialist. There are new protocols: cardiac surgery, joint replacement, interventional radiology. Primary care doctors now are reduced to helpers and middlemen. The specialist became the hero. And competition discouraged collaboration. Patients became body parts. The system becomes hierarchical and divided, and the different medical disciplines separated into silos, with the primary care physician at the bottom. There is the missed opportunity for the primary care doctor to lead in preventative medicine. There are medical models that promote collaboration. The fact of the changing medical landscape that doctors will specialize, but collaboration will bring them back to a relational approach. Kaiser Permanente has attempted to create an integrated model, and they've worked really hard on not having a hierarchy and having the doctors collaborate. And that's what we need. If we have specialists, that's wonderful, because they're going to be very, very focused and good at what they do. But then we have to put the pieces back together. In his book, Uncaring: How the Culture of Medicine Kills Doctors and Patients, Dr. Robert Pearl wrote, "There is a great danger in doctors who default to intuition over science, but there's also a danger in stripping doctors entirely of the ability to exercise independent judgment. Intuition-based remedies and one-time experience are no substitute for rigorous analysis and statistical significance, but our lives and our world would lose so much of our humanity and its meaning without people-centered cornerstones of physician culture balancing these two ideas in positive ways." And it might need to begin in medical school. Voltaire said, "Doctors prescribe medicines of which they know little to cure diseases of which they know less in human beings of which they know nothing." So I worked in health information management and clinical documentation. And I'm saddened by the failure of something that had so much possibility for a process relational type of advance in connectedness and communication. The shift from paper charts to the EMR, electronic medical record, was supposed to make healthcare more efficient when all healthcare facilities at multiple levels could access your health medical record, an interconnected web of information. EMRs were implemented in hospitals and doctors' offices, and it's rare to use paper charts anymore. So why am I driving my mother to multiple lab appointments before each different medical specialist appointment? Because the EMRs were never linked to create the communication network as was originally intended. And why was that? Because in a for-profit industry, there are multiple versions of the electronic medical records, and they don't talk to each other. I worked at 3 major hospitals and a couple of hospices, and every single one used a different company to provide their EMR. There's about 1,200 EMR companies, all with their own version, and doctors are spending more and more charting time than they do with their patients. The relationship between doctors and technology is complicated. On one hand, technological advances have made it possible for physicians to prevent cancer and greatly reduce deaths from heart attacks and streamline overall patient care. On the other hand, doctors bemoan computers, medical technologies, because they stand in the way of the most important relationship, the one between the physician and the patient. And thanks to rapid digitalization of healthcare, many of the doctor's time-honored skills and virtues have become irrelevant or obsolete, seemingly overnight. In a profession now fueled by clinical algorithms, electronic health records, and sophisticated machinery, physicians are being told that their clinical institution and decades of experience no longer matter and could even prove harmful to patients. So what are the possibilities? I sing the body electric, but in the expression of a well-made man appears not only in his face, it is in his walk, the carriage of his neck, the flex of his waist and knees. Dress does not hide him. The most important determinants for making the right diagnosis and achieving the best clinical outcomes are, number one, how well physicians are supported by information technology. Number two, how well their entire medical team works together. It's that collaboration. Number three, how consistently the doctors on that team follow the best national guidelines. Number four, how often the physician treats a particular problem or does a particular procedure. So did anybody watch Ted Lasso? A soccer team works well together when they collaborate. No heroes, team first. It seems no matter how great Jamie Tart played and how many goals he scored, the team was still losing. And in this case, if you haven't watched Ted Lasso, Jamie Tart is the leading scorer, huge ego, popular player on the team, but very self-centered. Rather than worship him, Coach Lasso keeps his focus on the team. Lasso encourages him to pass to Sam to help make the players around him great. Sam is the primary care physician. The game is the patient, except when the game is lost, the patient dies. Collaboration is key. Relationality matters in medicine. So let's consider the specialists, the cardiologist, the neurologist, the nephrologist, and then the primary care physician. Imagine if they collaborate. They paint a more accurate picture of this patient. The picture should be a biopsychosocial spiritual picture as well. And this would better tell the patient's story. In a process relational world, we know that we are more than our body parts. The neurologist Oliver Sacks, the poet laureate of medicine, developed an effective clinical method treating the patient as a complete person rather than as a defective body part. He wrote that clinicians are concerned not simply with a handful of symptoms, but with a person and his changing relation to the world. He based his method on 4 dimensions of the patient's personhood: bodily, the mental, the emotional, and the spiritual. Sachs' notion of personhood was holistic rather than fragmentary, in that each dimension of personhood depended on and was integrated with one another. He saw the mental not just as a separate function of the brain, but rather a comportment of the entire person, including both the emotional and spiritual dimensions. A person would be mentally sharp, not only if the brain is functioning properly, but also if the emotional dimension is stable and the spiritual dimension is sound. Sachs drew stories out of people because he wanted to know how his patients' experiences in the world. And he paid attention to the people who are left out. He collected their stories and storied them back into the world with his writing. Slow medicine. Dr. Victoria Sweet. She wrote a book called Slow Medicine, and it's a whole movement. After she discovered Hildegard of Bingen, a 12th century mystic and a nun who also wrote a practical medical text, Dr. Sweet completed a master's degree in the history of medieval medicine called Earth, Air, Water, Fire, the Medicine of Hildegard of Bingen. And then she wrote Body as Plant, Doctor as Gardener. In God's Hotel, a hospital and a pilgrimage to the heart of medicine, Dr. Sweet lays out her evidence in stories of her patients and her hospital, and for some new ideas about medicine and healthcare in this country. I love both books, God's Hotel and Slow Medicine. Veritas. O most honored greening force, you who roots in the sun, who lights up in shining serenity within a wheel that earthly excellence fails to comprehend, you are enfolded in the weaving of divine mysteries. You redden like the dawn, and you burn the flame of the sun. Hildegard von Bingen. Veritas. It comes from the Latin word for Greek, and it was used to refer to the color of plants, as well as meaning vigor and youthfulness. Dr. Sweet points out how Hildegard also used the word veritas in the broader sense, the power of plants to put forth leaves and fruit, and analogous intrinsic power of human beings to grow and heal. Inspired by Hildegard, Sweet began to ask herself, as she was treating her patients, whether anything was interfering with the veritas, or intrinsic power to heal, to relate to healing like being a gardener who removes impediments and nourishes in a sanctuary-like setting. Our current model is a materialistic viewpoint with body as machine and doctor as mechanic. A process relational approach would see the patient as a plant and the doctor as a gardener, as do Hildegard and Dr. Sweet. Against the backdrop of our assembly line model of medical care, which we receive cookie cutter prescriptions for complex health matters, slow medicine provides the necessary time and asks the relevant questions for optimizing general wellness and healing chronic illness. In some cases, we may need to schedule a surgery. In other cases, we may need to cultivate loving relationships. In still other cases, we may need to engage the artistic self-expression through dancing, painting, writing, or playing a musical instrument. Narrative medicine. The premise of narrative medicine is how a patient speaks about his or her illness or complaint is analogous to how literature often refers to a plot or an interconnected series of events with characters the patient and others, and it's filled with metaphors, picturesque, emotional, and symbolic ways of speaking. And that becoming conversant with the elements of literature facilitates understanding and the stories that patients bring beyond attempts to reach an accurate diagnosis. It attempts to address relational and psychological dimensions that occur in tandem with physical illness. Narrative medicine aims not only to validate experience of the patient, but encourages creativity and self-reflection in the physician. This approach is compatible with process thinking and would have doctors consider what is meaningful to the patient. They would be people instead of body parts. So, Amber's story. Amber had just graduated from high school. She was an overachiever, taking college classes to supplement her high school classes. In high school, she played soccer, softball, basketball, and ran track. Amber was always volunteering to organize events for good causes, including a blood drive at her high school in 2015. Lots of kids showed up to give blood, including Amber. And when the nurse pricked her finger for the initial test, Amber was turned away and given a brochure and sent on her way. That night, Amber, who was unconcerned, shared with her mother. Her mother asked why she was turned away. Amber shrugged her shoulders and said, "I don't know why, they just gave me this stupid brochure." Her mother asked to see the brochure. It was about iron deficiency anemia. Amber's mother was concerned, and she took her to the primary care doctor. He did a full workup, and that's how they discovered her colon cancer. That wasn't the last of the bad news either. The doctor called Amber's mother, who was in her car at the time. He asked her to pull over to the side of the road. She knew something was very wrong, and she was right. Amber had a brain tumor. Amber cried at first, but composed herself, packed her bag, and went with her mother to the hospital. There, the neurosurgeon would drill a hole in Amber's skull to determine if the tumor was malignant. It was. Amber and her mother spent the next 2 years on surgery and treatments. Amber was often very sick from the chemotherapy, but she remained brave. She endured a 7-hour surgery to remove the brain tumor, and it was a success. Next was dealing with Amber's colon cancer. Amber had hundreds of polyps, which are overgrowths in the lining of the colon. Amber's polyps extended from the intersection of her small intestine, and they lined her entire colon. And there were high odds that one of them would become malignant. The recommendation was to remove her entire large intestine, all the way from end to end. This surgery would leave Amber with an ileostomy, and that means the end of her small intestine would be connected to her skin. For the rest of her life, Amber would have to wear a bag to collect her feces. For the doctors, having an ileostomy wasn't a big deal, but for Amber, it was. The physicians encouraged her to proceed because the risk was high that she would develop a malignancy. But 18-year-old Amber didn't see it that way. In her eyes, the right answer involved going to college and meeting boys without an ileostomy bag in tow. A compromise was reached. The doctors performed a colectomy to remove just enough colon to retain bowel function without a bag. This is Amber's choice for her healthcare goals. It's risky, yes, but this is the point. Was it meaningful for the patient? How does one define quality of life? And what choices support our quality of life? We can say no, we can say yes, we can seek alternatives because this is our story. Doctors can tell you about the protocols and best outcome, but you can share your story with them and see how these fit together. flow becoming interconnectedness. Physician Leola Furman and social worker Edward Kanda teamed up in their research and added spirituality to the biopsychosocial model. This model includes spiritual considerations, and it's used by chaplains and social workers. They're trained in diving into these realms. The biopsychosocial spiritual pathway model is a theory used to describe how the spheres of biology, psychology, socioeconomic factors, and spiritual or religious beliefs overlap and directly influence each other. The body is not just a body. One of the most important elements to consider in holistic medical approach is the family and the social system, because they are the support. To effectuate appropriate care, the receptive and responsive caregiver needs to be part of a coordinated network of services that considers the families and communities that are affected by the patient. And we should start looking at the need rather than a system of care to which the individual is made to conform. Looking at need and where the patient is now from multiple angles would, by a process relational approach to the whole person thinking, it would have addressed my father's situation by providing communication, preparation, and spiritual support. For Mr. Butler, he would have never received a pacemaker because of his dementia. Kanda's influential definition of spirituality reads, the human quest for personal meaning and mutually fulfilling relationships among people, the non-human environment, and for some, God. A person's sense of purpose and meaning, worldview, or faith affects health and how well the body recovers. Now, a number of studies have shown that being religious or spiritual is associated with a lower risk of death, and this may be due to social support and reduced rates of depression. People in blue zones tend to have a life purpose. They tend to include activity, they have a healthy diet, a better outlook that includes a spirituality, and they have connections. So it's a whole picture that adds to longevity in these areas that they've studied. And I worked at Loma Linda University Medical Center, and they're vegetarian. I don't know if that's one of the reasons, but health is a part of their spirituality. Creative transformations. Hospice is unlike many forms of traditional medicine, and hospice treats the patient, not the disease. The purpose of hospice care is to provide comprehensive expert care that provides support for patients in the last months of their lives. Hospice tailors a plan of care specifically designed with the goals of the patient and family in mind. The philosophy of hospice care is to provide support for the patient's emotional, social, and spiritual needs, along with a treatment plan designed around symptom management. The person is more than the disease or condition. Hospice is about life. Hospice reaffirms life, focuses on dignity, brings comfort and quality to the time remaining. Hospice does not hurry death. Hospice does not prevent death. Death is the inevitable destination at the end of hospice, and like any destination, the traveler must prepare for arrival. So my question is this: why do we have to wait for an integrated medical model until the last 6 months of life? My mother's story. My mother has a terminal illness. She was taken to the emergency last year, and that's when we learned the news. She has non-alcoholic liver failure. This came as quite a shock to my brother and me, but I do understand this disease process. Her hospitalist physician did somersaults around my questions to avoid the D word, death. I asked again and again, how much time does she have? He told me about a surgery that was very unlikely for her to have had. It was called transjugular intrahepatic portal systemic shunt, TIPS. I couldn't believe this was happening again 25 years later. The doctor couldn't look at the bigger picture. He couldn't tell me about the obvious outcome in a terminal illness. He was focused on keeping a liver from doing what a failing liver does. All he could think of is there's a way to relieve pressure and the fluid that backs up. TIPS is the procedure that involves inserting a stent into to connect the portal veins to the adjacent blood vessels that have lower pressure. I knew that my mother was not a candidate for this procedure. I pressed the doctor again. He was not going to get away with this. I said, I need to know what we are looking at because my family needs to plan for what is to come. He still avoided my question. And finally, I said, look, I work in hospice and I know a thing or two about liver failure and death. I need you to be direct and honest. I'll know if you are not. And finally, he talked to me about her prognosis. So I called a family meeting, printed diagrams, and explained the disease process to my brother and sister-in-law and my mother. I'm determined to do it differently this time, to do for my mother what I couldn't do for my father, to make knowledge-based decisions and prepare not only the body, but psycho-social, spiritual part. I live an hour away from my mother, and it's difficult to get away to drive her to doctor's appointments, and she has many. She has her primary doctor, her gastroenterologist, her endocrinologist, her cardiologist, her hepatologist, and they each order blood tests, which means going to the lab multiple days in advance of the medical appointments. There are multiple medications to keep track of, and we must get her weight every day and measure her waist to see if fluids are accumulating. Recently, my mother was hospitalized for gallbladder issues, and they will not operate due to her liver failure, making her high risk. So she should watch her diet and avoid certain foods. My brother and sister-in-law berated her and lectured her about her food choices, and I stepped in and initiated informed decision-making. Mom, you know your condition, you've been informed, and this is your choice, the choice you make. Your food choices have consequences, and that's all I'm going to say about what you choose to eat. I want her to have quality of life. And how many days will following a strict diet buy her? It took time, but my brother and sister-in-law relaxed. We all relaxed, and we focus on quality over quantity. One way to gain quality time would be to cut back on doctor appointments. I spoke to her primary care doctor about having him manage most of her care so we could spend quality time with her instead of spending what little time our busy lives afford going to doctor appointments. Not only did he decline to do it, he stated he couldn't do it. I felt like I was hitting my head against a wall again. At this stage in her health, my mom is not appropriate for hospice. Appropriate is the language that we use in hospice when determining if somebody will qualify for hospice. It means we expect them to die within 6 months and to decline in health month after month. Although my mom has a terminal diagnosis, she's stable. Her liver failure is compensated for now. I'm not in a hurry to put her in hospice, but I don't want to be on the medical conveyor belt. I want to slow down, cut out unnecessary appointments. I want slow medicine and options that are not cookie cutter care, but there are no options, and we're stuck in fast medicine. So even as passionate as I am about whole person care and quality of life, I'm trapped in a system that I feel is holding my family hostage to compartmentalized medicine. Medical care that is between the current system and hospice would help my family right now. I wish for a more integrated system for all ages and stages of life. I wish for a process relational understanding of our world so that we adopt systems, including medical systems, that are compassionate and healing. We are stories. Medicine is a science, and we as process thinkers have identified that science can have a religion-like ideology that advocates for scientific reductionism, scientific authoritarianism, political technocracy, and technological salvation, while denying epistemological validity of feelings and experience such as love, emotion, beauty, and fulfillment. But often in American medicine, even science is overruled by greed and profit. They no longer practice an art, rather follow a bureaucratic one-size-fits-all system. A new attitude is needed in medicine, one that embraces the data of best outcomes, leaves room for intuition, but not bias, values the primary care physician and the specialist equally, and shifts away from primarily reactive care and moves toward preventative care. And what are the biggest obstacles to process relational approach to medicine? Competition and hierarchy among physicians, denial of death, greed, as well as lack of individual healthcare goals. Identify your healthcare goals to include what is important to you for wholeness of life and measure your treatment options against these goals. A big flaw in our current medical model is that our sole commitment to what is visible only. You can't see the soul in the mirror. You can't see the connections that keep you alive and are part of the living, breathing world. You can't see your thoughts, your feelings, your wishes and hopes and dreams and fears. Modern medicine continues to focus on the physical. And until we reinvent the body, giving due importance to its invisible reality, the medicine we get will be forever limited, insufficient, and slow in its evolution. But it will be fast in its treatments. We must teach our doctors that the essence of medicine is story, finding the right story, understanding the true story. Healthcare, on the other hand, deconstructs story into 1,000 tiny pieces, pages of boxes, check marks for which no one is responsible. Quite often, we can slow down, and we should slow down. Oh, I say, these are not the parts and poems of the body only, but of the soul. Oh, I say now, these are the soul. And I'm going to invite Mary Elizabeth to read this poem that she wrote that I think really talks about what I've been talking about today.
Oh my, I didn't expect to be reading, but here we go. Living or dying? Are we living or dying as we make choices about how to live? Which treatments to accept or set aside? Which adventures to seek or hold in memory and dreams? How much to give ourselves to bold living, serving, creating, and how much to leave for others to give? Are we living or dying? Yes, and yes. But how do we live today?
Thank you. And I'll share any of the books that you want more information on. Thank you.
Kat, that was fantastic. Thank you so very much. I noticed that a poem came on the screen just before your face appeared again. And was that one you wanted to read?
Oh, you know, it's from the song, in the 1980s, Generation Xers will know the movie. Oh gosh, I'm going blank on the movie. They had this song, I Sing the Body. Oh, Fame. I sing the body electric. I celebrate the me yet to come. I toast to my own reunion when I become one with the sun. And I'll look back on Venus, I'll look back on Mars, and I'll burn with the fire of 10 million stars. And in time, we will all be stars.
Thank you so much, Kat. Thank you.